Hello, everyone, and welcome back to another episode of the Oncology Brothers podcast. I'm Rahul Gosain here with my co host and brother, Rohit Gosain. Today, we're diving into our Tox Check series, focusing on managing side effects from key treatment in metastatic colorectal cancer. For this, we have Dr. Pashtoon Kasi from City of Hope with us. Pashtoon, thank you so much for joining us.
Thanks for having me.
Today we are discussing two important drug classes, bevacizumab, an anti-VEGF antibody, and two anti-EGFR antibodies, which are panitumumab along with cetuximab. They are very prominent in GI space, but also in other cancers and in some benign conditions we utilize them as well, particularly bevacizumab. Before we dive into any of the side effects and their management, can you give us a brief overview on these particular drugs?
For sure. And as a GI oncologist focusing on colorectal cancers, the first time I meet patients when we talk about options in the metastatic setting, it's important from an awareness standpoint that it's not just about chemotherapy. There are drugs that are biologics or targeted therapies that are focusing on either the tumor itself, like anti-EGFR antibodies, like cetuximab or panitumumab, or the cancer's tumor microenvironment, which relies on simplistically feeding off from the human host itself. So drugs like bevacizumab and some of the other anti-VEGF agents, which are V for the vessel, are focusing on the vasculature, are agents that are often, in most scenarios, added to a backbone of chemotherapy to make it more effective and to help prolong survival. In instances, especially for anti-EGFR in later line settings, can also be used. At a high level, these are not chemotherapies, these are targeted therapies, biologic agents focusing on unique aspects of the cancer or the tumor microenvironment. For some, they are applicable and helpful for all patients with colorectal cancer, whereas for certain agents, as we'll discuss more, for anti-EGFR, there are options for a select of biologic set of mutations for which the drug may or may not be an option. There is a selection or a hyperselection that is now going into play for some of these biologic agents.
Pashtoon, thank you so much for laying that foundation. With that in mind, now let's dive into the side effects. Starting off with bevacizumab, we often have to worry about hypertension, proteinuria, risk of bleeding, or even thrombosis, and a small risk of perforation. Pashtoon, any clinical pearls around these common side effects when it comes to bevacizumab?
As you rightly pointed out, the list is exhaustive. For the most part, when I talk to patients or caregivers or colleagues from other disciplines who might be caring for the same patient, since it's affecting the vasculature, a lot of these side effects are around bleeding, clotting, or in different forms of healing. From a practical standpoint, one arbitrary thing to keep in mind is the washout of about 6 weeks or so before any major procedures. It's not like patients on anti-VEGF can never get surgery, of course. What if somebody's in an accident or needs some sort of emergency operation while they're on these therapies? The fact that you have cancer doesn't mean you can't have other problems. There is evolving data in that space, but for the most part, if it's an elective surgery, a major surgery, it does impair the wound healing, which is a mechanism of its action. It's about good communication between the patients and other caregivers and specialties that might be taking care of him to make sure that if there are any planned procedures, whether are they related to the cancer or, let's say, for example, if somebody's undergoing a liver surgery or colon surgery, and arbitrarily we would hold the bevacizumab 6 weeks prior, sneak in a few more rounds of chemotherapy till the surgeons are ready to take the patient to allow for no issues with the wound healing or fistula and other issues that might happen. It's also important, as you mentioned, perforation. Often it's important to realize when you have patients diagnosed with cancer, sometimes it could be from the bevacizumab working too well that you could have perforation of the tumor. So it's not that the bevacizumab is causing perforation all over the body. If you have chemo working too well, sometimes you can have perforation. One practical aspect to keep in mind is if somebody has a stent which is now being placed often in patients with blockage, then that's in many ways considered an absolute contraindication to getting anti-VEGF because the risk of perforation, which is about 3 to 5%, can go up to 25% or more. So that is one situation where we avoid the use of this agent. The other common thing that I tell patients is not necessarily a side effect, but an on-target effect is that almost every patient has some elevation of their blood pressure. So good home monitoring, figuring out if they already have a a bad concomitant hypertension that's not poorly controlled. We want to make sure there's an adequate plan in place. Worsening of existing hypertension or developing hypertension that requires medication or management is imperative. So we can adequately not only focus on the cancer part of things, but the supportive care part of things as well.
Thanks so much for pointing all that out. With regards to checking for UA, we will always want to make sure that we've ruled out proteinuria, especially with the utilization of bevacizumab. Now, I have a patient who has hereditary telangiectasias, has been on bevacizumab for many number of years. Is there a need to be checking for UA every single time?
Just a few weeks ago, I was talking to a colleague about the UA, and the remark made was that was the most useless indication or a test that we do for patients with like metastatic colorectal cancer in terms of checking for protein. So, and having been at different institutions, the practice varies. So it's not that it's not helpful at all. We have to keep in mind the bigger context of things. You don't necessarily need to check it every time. Every other time is not unreasonable. It might be more relevant in some cases to have more frequent monitoring when somebody already has CKD, kidney disease, and proteinuria or other issues, so that we at least don't accentuate that problem. I think some of these are also recommendations have to be interpreted on a case-by-case basis.
And just before we move into the anti-EGFR space, one last question would be utilization of anticoagulation or antiplatelet agents. Can we safely still consider bevacizumab in these patients?
I was going to mention one important aspect of anti-VEGF use and when it comes to thromboembolism, because a lot of our patients are, for the most part, I worry more about clotting than bleeding. I've had patients who already had GI cancers that are bleeding, and the question is, you're giving me an anti-VEGF agent, is it going to worsen the bleeding? It's usually the opposite. And as you pointed out, even in a bleeding benign disease like telangiectasia, the reason why you give anti-VEGF is to stop the bleeding episode. So it's usually the opposite. If I'm trying to give anti-VEGF to somebody with newly diagnosed metastatic colorectal cancer, the bigger worry I have is that the chemotherapy itself, having a cancer itself, is a hypercoagulable. If you look at some of the recent guidelines from ASCO and some of the hematological groups, there is this Corona score that has been developed by one of the GI oncology colleagues, which kind of looks at some basic indices to see should we even be preventively doing anticoagulation before we start systemic therapy in these patients. And you and I often have patients who are getting scans and they find the incidental PE, or they already have a clot to begin with, or they develop a DVT during treatment. So for the most part, outside of those absolute contraindication, if somebody had a heart attack or a stroke within the last 6 months, the thromboembolism part usually doesn't worry me. I would say with guidelines of even preemptive anticoagulation, and it's not uncommon for a lot of our patients to be on these DOACs, novel anticoagulants, to look at from a making sure that they don't develop another clot. Most patients are on it, and I've seen cases and shared cases with colleagues where they were hesitant to add anti-VEGF. You don't want to exclude an important lifeline for some of these patients. The clotting, I would say, is part and parcel of what we do, directly or indirectly related to the cancer or the treatments itself. So there are no reason to avoid the use of anti-VEGF in that specific scenario.
Thank you so much for covering that. And again, that's why these discussions are so important. We want to make sure we're getting comfortable with these drugs, even though they've been approved for decades now, so that our patients can get access to this and are staying on these medications for years and years. All right, let's switch gears to anti-EGFR drug, starting off with Panitumumab. This was first approved in 2006 in refractory settings, but then got approved in first-line settings for RAS wild type. When it comes to Panitumumab, we often worry about skin toxicities, nail changes, electrolyte imbalances. Pashtoon, clinical pearls in managing some common side effects with Panitumumab.
While none of these toxicities at first glance look like anything that's going to be medically life-threatening, these can be disabling and are a major quality of life issue if not controlled well, to the point where I've had patients where they absolutely would do anything but not try the anti-EGFR again, because the first time around, whenever their treatment was, they just had such a bad rash, for example, that they often end up saying that I had an allergic reaction, which again, going back to what exactly transpired, is not necessarily a side effect. Again, a non-target effect. The E of the EGFR, I tell my patients, the E stands for the epidermal part, which is the other word for skin. The receptors are the same, so Similar to like anti-VEGF, patients who have the high blood pressure, in this case anti-EGFR, the patients who develop some sort of a rash, there are multiple studies quoting different numbers, but there is improved survival in the ones who get some sort of a rash. It's good that we see some rash. We don't want it to be morbid to the point where people are calling it an allergic reaction, but controlling it well over the years has been a challenge. So one thing that I often tell patients as well as colleagues, and I think that's true for a lot of supportive care that we do, preemptive strategies as opposed to reactive strategies are being endorsed, are showing better quality of life, better outcomes, longer duration of periods of patients being on treatment, whether it comes to some of these pills, TKIs, or anti-EGFR. Some of the earlier studies, the so-called STEP study, where they had a therapy evaluation protocol for Panitumumab, published back in 2010, looked at simplistically these skin moisturizers, steroid cream, doxycycline acne antibiotic as a preemptive strategy as opposed to a reactive strategy. They showed that that can significantly improve the quality of life and these issues that may arise. We were making sure that preemptive strategies are in place, whether it's some of these steroid creams, and then there are some topical antibiotics that are available that are often used for acne. Managing some of these rashes is just like managing teenage acne. Anything in that aisle is the best friend. I often make sure that they see a dermatologist in parallel, because while we can talk at length about cancer treatments, they still can manage acne better than us. They may have different formulations for what to put on somebody's face, different intents of topical steroids and which antibiotic lotions and creams. Not that you need to see them before you start treatment. Often I would, as the STEP protocol dictates, have the topical creams and lotion prescription already at the patient's pharmacy, have a prescription for the doxycycline antibiotic to start preemptively. Again, you don't have to be on it all the time. So I tell my patients it varies case by case. If you are doing okay after a few days with the anti-EGFR, it's still an antibiotic. It kills the good bugs as well, not just the bad bugs. We're giving it to you for the acne form rash, so you can elect to stop it and just cycle it every 3 to 7 days whenever you're getting treatment, and skip it the week if you're not having the rash or if your rash is not too bad. But if it is bad, continue the antibiotic.
Partnering up with these specialty colleagues is extremely important. We certainly have the opportunity in tertiary care centers to do that, but in rural settings or community settings, sometimes that's not possible. Having preemptive approaches is extremely important. I do utilize doxycycline 100 milligrams BID to do that for 4 to 6 weeks, and if patients are doing well beyond that, continue on with Q-Day. Rahul and Pashtoon, is that your approach as well?
Yeah, so depending on the severity of the rash, definitely doing it for at least 3 to 7 days a week of therapy on a case-by-case basis, skipping the days when you don't feel the rashes could just be managed with topical care. On the tertiary care issue, it's far more difficult to see a dermatologist soon enough in some of these places. I often tell my patients it's not about your care here at my institution. It's about whatever care is feasible and practical for you, and it's an ongoing process for the months and years to come. They can very well see any dermatologist closer to home. So I've often partnered with the local dermatologist, which is more convenient for him or her to see on an ongoing basis.
And Rohit, when it comes to antibiotics, doxycycline or another option is minocycline. It also depends on where and how you were trained. So a lot of us lean on one or the other antibiotic with very similar improvement in their acneiform rash in that settings. And while we're talking about rash, recently amivantamab was approved for lung cancer. And rash with that drug is also very prominent, looks very similar to what we've seen with Panitumumab and Cetuximab. And believe it or not, they're actually borrowing literature from what we're doing in GI, antibiotics, starting off with topical ointments and steroids and so forth. So these drugs are coming to us at a rapid pace, but managing these side effects is going to be important. With Panitumumab, we have to worry about skin toxicities. But we can see this with Cetuximab as well. Any unique side effects when it comes to Cetuximab infusion reactions, Pashtoon?
Yeah. So it's an interesting tale of how there were places in the country when Cetuximab came around where they were coding allergic anaphylactic reactions happening at the time of infusion on a routine every other or every third patient. So it kind of boiled down to looking at the geographic areas that were affected, which academic institutions were reporting. So it kind of boiled down to the exposure to a tick bite that has homology to the reaction that has the same drug structure. If you get a chance, for anybody interested, it narrates the tale in one of the articles published in New England Journal back in the day. So when it comes to patients' history as a GI oncologist, often knowing which state they live in or grew up in has bearing depending on where you practice. There are some institutions in the country, if you are in the belt where that tick exposure happens, that outside of a clinical trial, the use of cetuximab is prohibited unless there is an indication that you can't use panitumumab. And since there are some indications like in head and neck where cetuximab is approved and some situations where panitumumab is not approved, that is one big difference when it comes to the anaphylaxis part of things to be mindful of from a social history.
I would be shocked if these drugs are not interchanged in the community settings just because of that fear. It used to be a board question where you had to be picking the right cetuximab or panitumumab based on where you're practicing in the country.
Pashtoon. For cetuximab, the weekly dosing is available. Also, biweekly dosing is available. And there are some dose modification that is 200 milligram per meter square or 150 milligram per meter square. And similar is the case with panitumumab, 6 milligram per kg every 14 days and 9 mg per kg if you're combining that with Kpox, which is every 21 days. Do you usually go down on the dosage or skip a week, or how do you maneuver through the toxicity aspect?
As you talk about toxicity, there is the time toxicity that is an important area that has been a topic of discussion over the last couple of years, which is the amount of time that patients are spending back and forth at the treating cancer center facilities. For the most part, it's actually a nice meta-analysis done by one of our colleagues, Dr. Parikh and Dr. Kopetz, and I happen to write the editorial on that topic, which is available online, which pretty much summarizes that biweekly or every 2-week dosing is as good as the weekly dosing. So we really don't need to use weekly dosing outside of indications for head and neck cancer or when we are doing it with radiation and other non-GI indications. But for colorectal cancers, the biweekly dosing, which is every 2-week dosing, it kind of syncs with the intravenous chemotherapy cocktails, FOLFOX, FOLFIRI, or just single agent irinotecan well. And again, in terms of the doses and combination, I'm a little wary of using the every 3-week dosing with capecitabine and oxaliplatin or Kpox or Zelox regimen, because in metastatic setting, it's one thing in the adjuvant setting where we're only doing 3 months of Kpox, 4 rounds every 3 weeks. You don't even need a port and can get away without needing the pump, which can be cumbersome. The regimen itself is not as well tolerated. So when you add something else, bevacizumab is okay, but adding that anti-EGFR can be challenging. I've seen many patients over the year where that combination then just threw off the entire cocktail altogether. Even though the 9 mg per kg has been studied, I'm wary of using that. I don't think all guidelines or formularies endorse the every 3-week panitumumab dosings. For the most part, it's the 6 mg per kg. Depending on toxicity, you can often just skip the dosing, or you can have dose adjustment, as you pointed out. And for the most part, I start with full dose, unless it's a, geriatric patient population where you have to be a little careful with what you're giving and how you're giving it. Adjustments, as you pointed out, are indicated. One other thing in terms of dose adjustment I wanted to mention is recent studies, the so-called IMPROVE study, or IMPROV without the E, that looked at skipping anti-EGFR after a few months of chemotherapy backbone. Not only did they show that the cumulative skin and other issues, quality of life, other issues were halved in terms of severity because you were taking a break off of the anti-EGFR. But if anything, it didn't compromise the actual duration after which you had to switch therapies. So whether is it leading to less resistance clones, you're definitely not losing on taking some treatment holidays planned into the individual patient story. Again, those are case-by-case decisions, but if anything, it's decreasing the toxicity and increasing the longevity. So it's kind of a win-win for our patients.
Pashtoon, are there any emerging strategies or supportive care measures that we should keep an eye out that are being studied or we should be aware of with these drugs out in the community?
One anecdote I stumbled upon as I was dealing with one issue that all of us who use either panitumumab or cetuximab or any of these anti-EGFR agents is the crazy hypomagnesemia, the electrolyte disturbance that often leads to symptoms, especially cramps and other GI symptoms. Also, from a medical standpoint, having very low numbers of magnesium has other implications. So I just want to point out it's not an intake issue. It's more of a magnesium wasting that's happening in the kidneys from the anti-EGFR. It doesn't happen right away, but after 2 to 3 cycles in, magnesium is a lab that by default is checked in anybody getting anti-EGFR for that very same reason. All of us struggle in terms of grams and infusion, time being spent there. We don't go around checking patients' labs every other day. The infusion we give to our patients that day is essentially just treating ourselves on that day. And a few hours later or the next day, it's back in the dumps because the faucet is leaking. As I was looking at this in more detail and also talking to some of my nephrology colleagues, I stumbled upon some of the studies looking at amiloride, which is a potassium-sparing diuretic. It's been years now. I make sure that every single patient of mine or who is on anti-EGFR, the moment they start having even low normal numbers, it's just a sign before you show up with a magnesium that's in decimal points, to put the patient on once a day. Again, you don't want to start off with that because it's still a diuretic and you don't need it right away. It's a cumulative effect that happens after 2 to 3 cycles, but then can be a big issue. We recently had another patient where I said, watch what happens as we start him. And the moment we did that, the hypermagnesium within a couple of weeks of the patient starting the drug goes away. I don't think that's as widely known, but once you type the drug and look at EGFR, some of the case reports and details go back to even anti-EGFR drugs or EGFR pills as well. This has been an ongoing issue from a quality of life and a supportive care perspective for years. I do want to mention that often the drug is used in combinations. One has to be careful about not necessarily synergistic issues in terms of side effects, but there are additive side effects. So if cetuximab is causing diarrhea, which is not an uncommon issue, and you throw in irinotecan full dose and 5-fluorouracil as well. Some of these patients, especially if they have an ileostomy or short gut syndrome, they're admitted in the ICU with dehydration and kidney injuries. So as we use these agents, there are the individual side effects, but the cocktail with which you use it together also can make a difference.
Thanks for pointing that out, Pashtoon. Thank you so much for providing detailed insights. This will help our listeners manage these drugs more effectively in their practices and improve patient outcomes and quality of life. For our listeners, let us go over a quick recap from today's discussion. Rahul, from the get-go with our platform, our goal has been to reiterate the current standard of care and talk about recent advances rather than focus on how the field is going to change in about the next 5 to 10 years. I've been really enjoying these TalksCheck discussions as they are making me more comfortable with some of these important drugs that we use day in and day out.
Absolutely.
In today's discussion with Dr. Pashtoon Kasi, we had a chance to touch on Bevacizumab, Panitumumab, and Cetuximab, drugs that have been available to us for over a decade.
Yes, Rohit, I couldn't agree more. Today's discussion was a good reminder to keep a close eye on the blood pressure and spilling of protein in the urine with bevacizumab, whereas managing skin toxicities to ensure we're not compromising our patients' quality of life while also improving their outcomes with panitumumab is important. Lastly, when it comes to cetuximab, being mindful of serious infusion-related reactions is going to be critical. This was indeed an insightful discussion. Thanks for tuning in. Make sure to check out our other TalksCheck discussions around antibody drug conjugates and CAR T therapies. We are the Oncology Brothers.